I just have one question. Explain to our audience why you're cooking a turkey in March.
As I said, it's
As I said.
I had a bunch of leftovers, like stuffing, gravy, all kinds of stuff, and it seemed absurd to throw it out, so I put it in the freezer, and then I realized in December that it's really hard to get a turkey much past December. So at that point, I was like, I better get a turkey. So I did.
So you got an emergency
I got
turkey?
an emergency turkey, and I did.
Froze the emergency
And what
turkey.
I will say to my defense, I did order like I think it was 7 to 9 pounds, but what came was like 11.5 pounds. So it took up a substantial amount of room in the freezer. And Katie's been complaining about the use of freezer space. So now we figured it's now or never. It's better just do it.
Can we just talk about how you have to speak in your defense about getting a turkey?
Yeah. Well, why I'm doing it? Because it does sound kind of nutty.
What kind of room are we in where
I mean, I think it's great to have a turkey outside of the time of Thanksgiving, but we live in an apartment in New York City that doesn't afford a lot of storage. We don't have like a chest freezer that we can.
No, a turkey's like a whole other
It's a-
tenant. It's a whole other human.
Yeah.
Like you might have to apply to like the building's board to even have a turkey in your
Yeah.
freezer.
It takes up an entire shelf of our small
Already
fridge.
small
Yeah.
freezer.
Yeah, it's true.
I love turkey. I don't care. I could eat
Do you know what do you know what is our number 2 tenant in our freezer?
it. No.
Bagels. There's like 10,000 bagels. As if
Why are you
as if
fancying bagels?
exactly
And
as if,
seeded rolls.
as if there was some like if we needed a bagel, we'd be like, well, thank God we have these 100 bagels at home instead
Wait,
of just walking to Bagel
hold on, wait.
Bob's.
I can't believe you didn't tell me this. We are half a block from the best bagel store on the planet, like arguably the planet.
I really like Bagel Bob's. I do. But I really like Apollo, and Apollo often has a line. And so if I want an Apollo bagel, if I go, I get a bunch of them and then I just cut them and freeze them, and it's so good.
I don't want to start geeking out about bagels because I think I really, really can, but I'm fairly certain Apollo Bagels makes them with like a little honey in their mix.
I mean, it's sourdough.
They're sourdough
That's right. That's right.
bagels.
They're sourdough.
They're really delicious.
Right. But you'd rather a frozen Apollo than a fresh anything?
I mean, honestly, the frozen toasted, I cannot tell the difference.
Well, I mean, we don't toast a fresh bagel.
Exactly.
Yeah,
Why would you
that's
toast?
true.
There's the difference.
Yeah, true.
What do you think about the places that will offer you the toast?
What is
I
it?
feel like a real bagel shop should never offer you a toast.
But they
bagel.
all offer
I like
toast.
when you
Do
go
they
there. No, they do, but I like when you go, like here, you can't on a Sunday.
Bagel Bob's will toast?
Oh, they'll do whatever you want. But if you show up on a Sunday and you say, "Let me get a plain cream cheese toasted," they'll toast it for you. But if you show up on like a Tuesday afternoon when it's not like crazy, and you say, "Yo, let me get one of them blah de blahs toasted cream cheese," they'll look at you. They'll throw a look, like, "Come on,"
Why on Tuesday?
because it's not crowded. Like they're not going to argue with you on a Sunday when the line's out
Oh,
the door.
I see.
But on Tuesday, they're gonna
judge
they'll
you.
Deploy.
They're
They'll
going to
de-
judge you for your.
and they should.
They're going to
They
judge
should.
you.
I mean, you just baked a loaf of bread. I don't want to go on a tangent here, but that's what editing's for. You just baked a loaf of bread. Like you cut that thing through. Maybe there's a little steam coming out of it, right? And I say, "Let me have a slice, please." And then I go and toast it.
Yeah, it's crazy. I agree. It's insane. You should not toast it.
Right. Okay. Anyway, I have to try an Apollo bagel. I haven't tried one. But...
Well, we have some in our freezer. We'd like to.
All right. So let's get done with
Why don't you
this.
take 10 home with you?
Yeah. All right. Last question. How many do you have in your freezer right now?
I mean, probably
Probably
a dozen.
8. No, I don't think 8. I mean 8,
Do you
not 12.
entertain with bagels?
It's
Well,
too
we
many
often have a
bagels.
lot of people here, and
Too many bagels.
okay,
It's bagel insecurity.
There's no bagel shortages.
It's bagel insecurity.
and there's
We
seeded
get up
rolls
early
as well.
enough in the morning that you can go on any weekend and get it before there's a line.
No, that's true. You guys wake up at 5 now.
We are up.
It's true.
Can we just let go of the bagels? That's really where the number one.
Or maybe half. I mean, let's ease in.
Like 1 emergency bagel, 2 fine. 8.
Kindness. The one, like, have you considered maybe cutting down to freezing a half dozen? That's good for an emergency.
Yes,
actually.
I will. I will.
I think 2 to 3 is the absolute
Yeah, I
emergency
think so.
amount.
We're trying to be open-hearted about this.
I mean, again, the only reason is that if it's crowded there, like, and I don't know if am in a pinch, then I just want to have it available. But I shouldn't be so
We
judgmental.
call this shtetl mentality in my house. It's like those carrot tops that you would throw away. Don't throw those away. You're gonna make a soup. Make a soup out of that. My freezer is filled
Carrot
with.
stock. I do love a good carrot stock.
No, come on. I mean, it's like, the carrot greens and the
Yeah, yeah, yeah.
onion tops and all that stuff that sits in my freezer for the one time a year I make.
Ooh, I don't do that. I will put it in the compost bin and happily walk my little butt to the compost bin on the
But you will
corner.
freeze 12 enormous balls of dough.
Yep.
Right.
Hmm.
All right, fair enough. All right. Well,
Here we are.
we may as well get started.
I think so.
Okay. Hi, and welcome to Outside the Loops. I am Ari Haberberg. I'm here with Vishal Thanik and Katie Weichman, both board certified doctors and surgeons. And we're here to talk about the pinch points that you face during your breast cancer journey. We're creating a body of work that you can consult as you need, and like a library. And this would be our third episode, episode 3, entitled "So You Need to See a Breast Surgeon." Is that right, Katie?
That is correct.
All right. So I need to see a breast surgeon. Can I ask, when does that happen? How does that come about?
So I think at the end of our last episode,
If
we
you
were
caught the exciting end of episode 2, if not, pause now and go back and catch the last 1 minute, and then you can jump back in just so you know.
Last week on
We don't
Outside
have
the Loops.
refreshers. How come we don't have, how come we don't have
Recap?
last
Recap.
week on, recap. Maybe we should do that.
This week on a very special
Yeah.
Outside the Loops.
well, last week we talked about I need a mammogram. And at the end of the episode, we talked about sometimes requiring a biopsy and then having an abnormal biopsy, either having a cancer diagnosis on that biopsy or precancerous diagnosis or a high risk diagnosis, high risk features. All of those things would prompt you to see a breast surgeon. And that another thing that could prompt you to see a breast surgeon also is being high risk yourself or having a high family history. And as we talked about also in the last episode, you perform a risk calculator on yourself, and your risk is higher than 20% over a lifetime or 10 years basically, then you should also see a breast surgeon.
Wow. Well, okay. So I guess my question is, so I need to see a breast surgeon. How do I find one?
That's a really good question. And likely you are going to be referred by someone who did the biopsy. So the radiologist that did the biopsy is likely going to refer you. Also, your PCP or OBGYN would likely refer to you. Often these referrals are within a health system. Most care currently is delivered in health systems, and mostly within that health system, there's a network of people that are known. So those are the most likely. Also, as we talked about in the last episode, there's a high incidence of breast cancer, 1 in 8. So likely in your inner circle.
1 in 8 women.
Correct. So likely in your inner circle, there's one or more people that have been faced with this and have gone through this. And you can lean on them to see if they have any recommendations of who to see. But I would say that you should cast a wide net in those networks. So ask for multiple opinions. And also would highlight that it should be a fellowship trained breast surgeon. So these are general surgeons who go to a specific fellowship for 1 year to learn about the treatment of breast cancer. That is the whole gamut. They're experts, honestly, in everything from the diagnosis, treatment, and they know the medical oncology side of it too. So you should go to a fellowship trained person.
I guess that's a good reason why, to answer the question, why wouldn't you, if you think you have breast cancer, go to an oncologist before you go to a surgeon? I guess a breast surgeon is sort of different than other cancer surgeons, would you say?
I mean, there's so surgical oncology in general has broader surgical oncology fellowship that treats different types of oncologic surgery, but there is a specific breast fellowship that only does breast things related to the breast. So it is a unique. It is a unique.
It feels unique.
Yeah, I mean, I think it goes back to the question of how do you ever find a doctor, right?
Well, how do you like?
Yeah, it's super hard. I mean, it's difficult for us to sort of answer that question because we're advantaged in this system, right? Like we know people, and when we need to find somebody, what do? We like call people we know or email people we know or text them and say like, who should we see for this or who's good for this? And that's really how we do it, right? There is no there's no obvious mechanism. So it is a very much a reputation, word of mouth. People who you ask people who you think know things and have some experience in an adjacent field, and you ask them who they think is good. That is like how it happens. And so for the average person who doesn't have that sort of referral network, I think it is always really, really challenging for people to find doctors. And so as Katie said, I think a lot of the times what will happen is you're going to be referred somebody. One of your primary care or the health system is going to refer you to someone. They are generally trying to get you in with somebody relatively soon because there are metrics that are tracked for this, and they sort of want you seen quickly. So you are going to be assigned to somebody or be given a name or maybe a couple of names. But we also do think that asking around is important, and you may not have the one person that you can absolutely trust with that info, but if you ask a number of people and it coalesces around a few names, I think that's a really as good a way as any. And certainly Katie's right. This is unlike some more esoteric cancers. Finding somebody that you know or 1 degree separated is not difficult. And so I think talking to other people and getting their feedback is a really helpful and useful way, because I do think this is a very important. This is a branch point in that tree, right? Like this is a very important thing. Like who you see here makes a difference, and doing your due diligence at this point. There are going to be times I think in this process for people where a certain decision will manifest many things going down the road, right? It will take you on a certain path. And so there are times when taking a little bit of time to really try and make a good decision is helpful. And this is one, as we talked about in the last episode. This isn't something where you need to be seen tomorrow. This is not an emergency. You have some time, and it is time to take a little bit of time to try and come to a good decision. And certainly this is also something you can see more than one breast surgeon. You can get a second opinion for this. Again, most of the time, you should have enough time to do that. So I think a combination of good referrals and trusting your gut and trusting your feeling when you meet the person as to whether or not you are, connecting with them is good. And I do think in general, I always tell people, trust yourself. I think we generally underestimate our sort of non-intellectual, non-cognitive decision-making paths, and I do think they mean something. I think we do understand things in a parallel way that's hard for us to articulate.
I agree. You make a really good point about. I think my instinct as the patient would be to hurry up and get this thing out
Yes.
of me as soon as possible.
Yes.
And this would be one of those times
Correct.
that it's worth waiting. But 100%.
Yeah, or just taking your time to make the best decision you possibly can. I think this is definitely one of those pivot moments, don't you think, Katie?
I think for sure. I think seeing more than one person is totally reasonable to get a second opinion, and
If you feel
like you need to. And then like I was lucky when I went through this because I knew I had thought about it. Like if this happens to me, who would I see? Because I just had thought about it. And so that wasn't a hard part of this for me. I was really advantaged. And I do think, though, it is psychologically, you do just want to get it out as soon as possible. Like when you find this out, you're like, it just feels like the clock is ticking and you're worried it's spreading. And And I think you can't underscore that enough for people. Like it's really hard. But as Vish said, it's not like this does not have to be done next week, but more like in the next month. So you'll have time.
Yeah.
Shocking idea, a month. All right. So what else? You mentioned that. What I was going to say. What else should one look for in a surgeon? I know you should find someone who's fellowship trained. That makes a lot of sense. Um, Someone who you may have heard from more than one person that you trust.
Yep.
You should point out, which is it sounds.
And your choice of the breast surgeon is very much going to define what system you're in, which hospital system you're going to be
Sure.
seen in. And the breast surgeon is often going to be the one who helps you coordinate all the things you will need after, right? So it's not just the surgery, but what oncologists you see,
What
that
plastic
what
surgeon
plastic
you
surgeon you
see.
see, who you see for radiation therapy if you need it. So there's a number. That's why we think this one's important, because this decision has a lot of downstream decisions that come from it. So certainly, the quality of this healthcare system you're in matters. This is not always a choice for people. There's in many parts of the country, you don't have a choice between 3 or 4 or 5 big healthcare systems. You may only have a choice between 1 or 2. So, or one. Quite honestly, one, as we have ridiculous consolidation of healthcare in terms of insurance companies and healthcare systems in this country that continues to go unregulated and unabated by politicians that should think maybe a little bit harder about this, but that's an editorial. So we can talk about that at a different time point. But you may not have those choices, but it is important to think about, like, same thing when you're asking people who they went for a breast surgeon, like, how was the rest of the experience? Did they like their oncologist? Did they like their the radiation oncologist? How was those things? Because in many communities, you may not have 50 oncologists to choose from. You may have a handful. So figuring out how step one and then a little bit beyond that is also super important too, because that's also going to really define your care. Who you see for the oncologist really defines your care. Who you see for
Ongoing.
radiation, yeah, it can change your entire pathway of what happens to you. So not to freak people out, but to just make people aware that these decisions are important, and they will affect not just what's going to happen to you in, say, 60 or 90 days, but 6 months, 9 months, a year from now.
10 years.
Yeah, these decisions. So a little bit of time here to make your best decision, it pays dividends, I think, over the course of the year and your life.
Can I ask a question that we didn't really discuss, but I'm curious about? I mean, you mentioned that there are certainly some areas where there's little or no choice of surgeons. I don't know if there's an answer to this, but is there any guidance we can offer to navigate a conversation or an assessment of the surgeon where you have no choice? Are there things that if there aren't, we can edit this all out, frankly. But if are there things to look for, questions to ask, things to not take for granted? It's a little out of left field, I know, but I think it could be valuable.
There are accredited cancer centers. So there's cancer centers that have to go through specific accreditation to get a cancer designation. So that's not like there's cancer centers like Memorial Sloan Kettering and MD Anderson. Those are freestanding. But within hospitals, they have a specific cancer accreditation. And looking for that in the hospital system, I think that at least then you will know that they're following all the guidelines that make sure that in a very regimented stepwise fashion that you're getting the best possible care at the standard of care and the guidelines.
Accreditation. All right, that seems to make sense.
I think that's an important thing.
Other than that,
I mean, it's the same. You should be comfortable with who you see. You should be comfortable with who you see. And I think that if you feel like you're not being listened to, if you're being dismissed, if you feel like there's no shared decision making, if you feel like it's a conveyor belt and you don't really then I mean, those are the things when I say like listen to your gut, I think you should listen to those things. And I think most people in most parts of the country have some choice. There are people who live in really remote and rural areas who I suppose have very, very little choice. But even then, this is something you can travel for. This is not emergency surgery, as we talked about. You can travel there. You can go to a larger center if you need to. This is care that absolutely happens generally on a outpatient basis. Some people will get their surgery and initial treatments at some places, and then if you end up getting chemotherapy, that can be organized by your oncologist in a different city and administered in the town that you live in. That happens in many places for many people who live outside of major centers. So that's where I think it's important to yeah, if you feel, especially if you feel like you don't have a great choice, traveling for that is okay, and I don't think there's anything wrong with that or necessarily negative about it.
I do think that mentioning the insurance system and what insurance, so I would say most things, even if you had emergency Medicaid for the breast surgery part of it, for having this, you could get that done at most places. Most federally funded hospitals they will emergency Medicaid. But if you have other sort of managed Medicaids or private insurances, some of them only participate with certain hospitals and certain systems. So you have to do that due diligence on your own to
Sort of figure that out.
But that's something you can either call the insurance company or call the hospital system and say, do you accept my insurance? And what does that mean?
Well, along the lines of that, what are some, while we're still choosing our surgeon, what are some, I guess, pitfalls or things that don't matter, though maybe about a surgeon, or things that we can ignore?
So I think sometimes people think that if you're the chief, it says the designation of chief of something, that you're a better surgeon. Chief is an administrative role, and they are accomplished people. And it doesn't mean they're not a good surgeon, but it's not, being chief doesn't equal being best surgeon. Chief is an administrative role, a leadership role, not a surgical title.
I know the chief surgeon, and I'll give him his number.
So that's not necessary. I'm not saying that it's necessarily they're not necessarily better.
Got it.
Got
it.
All the chiefs are going to email you now.
Now you're in trouble.
They're going to be like, we hate you, Katie.
My fault.
It's just
no dissing. We're not dissing anybody, but we're just
absolutely
saying.
Not.
I think people sometimes will overvalue that. And what you said, like that's what people will say.
Yeah.
Like this is so and so's.
Yeah, I got the number of the chief surgeon. Right.
I don't think that's necessarily true.
And a good administrator would be like, yes, I have a great surgeon to send you to. All right, I'm making trouble for us. Sorry,
but in the absence of that, I don't know that I have that much.
Okay, yeah. Well, that's a lot. That's a huge branch that people get pulled off of. All right, so we've talked a little bit about how we shouldn't necessarily rush. We should take the time to make the decision. It's an important decision. How much time is a reasonable amount of time to do this work? This seems like an important thing to know.
So I think there is data looking sort of back at people's outcomes over time, like how you do with your breast cancer and time from diagnosis to treatment. And I think the most recent sort of observational study looked and basically shows that 8 weeks, like from delay in care greater than 8 weeks. So if from diagnosis to surgery, if it is greater than 8 weeks, then you have worse outcomes over time. And that's the goal, I would say, would be within 30 days. That is the goal. But between 30 and 57 days, that time period, according to this most recent large observational study out of the University of Wisconsin, that is a safe time period.
Okay. So as soon as possible, obviously, but owing to the value of making good choices,
Yeah.
and how important the choice
Yep.
is. A few weeks of meetings and research is not.
Weeks maybe not, but you should not also necessarily just jump into the first thing without a little bit of vetting is what I would say.
I'm always trying to get you guys to give me like an exact number,
Yeah.
and you're always
No.
telling me to get pissed off.
Yeah.
Right.
And
Okay.
then yeah, and then I think it's important to understand sort of what a breast surgeon does. I think for most patients, the breast surgeon really is sort of the quarterback.
Quarterback, yeah, they're the point person.
They're the point person for most patients and are the most sort of consistent person I think that most people see over their lives and their time.
So what can I expect in my meeting with the breast surgeon? I've chosen one. I've chosen one, and I'm meeting with them. What
So
do I hear?
I think they're going to first go over your diagnosis and go over specifically. So there are different types of breast cancer. Not all breast cancer is the same. And there's two sort of main branch points, I would say, that, and they'll discuss that with you. There's ductal cancer and there's lobular cancer. And that's either of the ducts or the lobules of the breast. They often draw a lot of drawings of the cancer. They are very visual. They'll sit you down and really explain everything to you. I've found that, I mean, almost all of them are really like kind and patient, and they want you to understand what this is and what it means. So, and then
And they're going to be talking to you about complicated things. When you talk about in situ cancers, aka precancers, when they talk about the different subtypes, when they talk about receptors, these are things we're not going to get into too heavily here. But they are talking about relative, they're complicated issues with a lot of nuance. And that's why it is really important to go to somebody that you can connect with and understand what they're saying, because all these things have implications for you, right? So having someone who's going to take the time and can communicate with you in a way that you can understand is really helpful, I think, both in terms of your outcomes, but just in terms of how you feel through the process. So that's it. But they are going to be talking to you a lot and going through all these sort of iterations, all these potential, differences for each particular person.
they will talk about these receptor types in breast cancer. I think we should mention the
Oh,
three
yeah, for sure.
important things. So there is estrogen receptor positive, there is progesterone sensitive, positive or negative. That means your cancer has receptors that attract those things. And then there's HER2, which is human epidermal growth factor receptor. Those are the three main things that they test for. And they have implications on the prognosis as well as the future treatment that you have. So they're going to talk to you about those in depth.
Okay. But we're not going to talk about them here.
Uh,
I mean, not so much in the sense of
Yeah, it feels like a conversation that there's too many permutations to. I don't know how we would get into the weeds very quickly, and I don't know how we would get out. And I'm not sure that as a blanket sort of conversation, it's particularly useful for people, right? So if you're in this situation, you're going to have X type, right? You kind of don't, and for you, you're an N of one, right? So your understanding of your particular type, your particular subtype really matters. And it's not just those things, right? It's the size. There's many, many things. So I think what we want to give people is some basic ideas of, okay, so these are the receptor types. This is important, right? What are the other things that are important? Is it lobular or ductal? Is it invasive or not?
not
How
invasive.
large is it based on imaging?
Let me make it this. Let me put it this way, because what we're really trying to do here, I think, is to help people avoid pitfalls. So let me ask this sort of overarching question: Are there, knowing the different types of cancer and the different presentations of them, are there any things we should talk about that people should know to look out for, that they might not hear from their surgeon, that will affect, I know it's sort of a tough question, but that will affect choices going down the road? Or
I think certain cancer subtypes, especially triple negative, when you don't have your biopsy doesn't light up for any of those three factors, that is a more aggressive type of cancer. And they are often given that specific subtype is often given chemotherapy before surgery. So because it shows you get to see how the tumor responds to the cancer, and it often downstages the cancer. So in a lot of triple negative patients, they get chemotherapy prior to surgery. And that is so and there are some people that don't for some specific reasons, but if you have triple negative cancer and no one at least discussed with you, hey, maybe you shouldn't have surgery first, it's like
That's something to
that's
look out
something.
for.
I think we should just start with the most common types, or the most common type, and what you would expect this conversation to roughly go like. So let's just say you come in. Remember, at this point, you've just had a biopsy, right? And you have had some degree of imaging, but you may not have all of your imaging done at this point. So at this point, you are likely to have a diagnosis that is done by a needle biopsy, right? You will likely have a mammogram, which should show you should show the characteristics in terms of the overall size of the mass.
And if your lymph nodes are involved, often they check with ultrasound to see if the lymph nodes look enlarged.
It
So they
doesn't
would
actually tell you if they're actually involved, but whether there's suspicion of
suspicious.
your lymph nodes or not. So that's generally what you're going to have, right? So, and you'll have some receptor status, but remember, this is a very, very small sample. So this sort of data that they are getting is very much preliminary data. It is not it is not there's it's preliminary data, is not the entire tumor. It is not the entire pathology. So it is a preliminary data which will drive decision making, but it is not the be all and end all. It's not the absolute final diagnosis. So if you come in and you have, let's just say, so an invasive ductal carcinoma, which is going to be the most common, and let's just say you have some receptor positivity, which again is most common, then that conversation that you'll have with your breast surgeon will why don't we start there, Katie, right?
Yeah, that's a good idea.
Okay, so let's just say I walk in, patient walks in and has this. What should they be expecting when they talk to the breast surgeon? What are the things the breast surgeon's going to talk to them about?
They're going to talk to them depending on about if they need genetic testing. So based on about 10% of patients have some sort of genetic association with their breast cancer. Certain qualities make them more likely to have that. So age of diagnosis less than 50, triple negative, if it's in both sides, and family history. So, and Ashkenazi Jewish heritage. So those things, they'll likely refer you, those qualifications, they'll refer you for genetic testing. A lot of people, this is like, I would say a lot of breast surgeons are ordering MRIs of both breasts. MRIs are more sensitive, so they'll assess the extent of the disease and also get a sense if it could be missing anything and may need further biopsies. And then if there's any worry about how the lymph node looked on the ultrasound, then they may order a biopsy of that as well.
Okay. I'm just curious. I always hear that they may recommend or may not recommend genetic testing. I'm curious why. You already have cancer. What are we gaining from learning that it was?
It just could impact what surgical treatment you're going to have. If it is genetically linked, you may want to have surgery on both breasts as compared to one breast. So you would like to know that. And also it impacts downstream further screening for other cancers, because a lot of the genetic syndromes like the BRCA gene are associated with other types of cancer, ovarian, pancreatic, etc.
So it'll change what you get screened for.
Okay.
So in general, it has some implication at the time of the surgery for this cancer, but it has more implications for things after this. So it is important, but it is not in general, it is, it's something that's going to happen in parallel. Things are going to be moving along, but it's going to have implications on both sides of it.
Okay, so there are a myriad of possibilities in the conversation with your surgeon.
And then they're going to talk to you about what you think you're going to, you're like, I'm going to a surgeon. I need to talk about surgery.
Yeah, exactly. That's what
So they're going to talk to you about surgery and what are the options.
And what are they?
So there's two options. There's lumpectomy, which is removing part of the breast, which is the cancer, and then a margin of tissue, which is of normal breast tissue around it. And then that is always coupled with radiation. So lumpectomy, and then after the surgery, you'll get a radiation treatment. And then the second option is mastectomy, which is removing the entire breast on the side of the cancer.
How long? It's a little bit of a diversion, but like how that you said a radiation treatment. Is it one treatment? It's a
We will talk about that more in the radiation
you
oncology
have a
episode.
okay.
But it is most likely weeks of radiation. There are trials to try and de-escalate the need for radiation in certain patients, but it's most likely about 5 weeks of radiation after surgery, and radiation prevents local recurrence of breast cancer. That's what it's doing. And that's why lumpectomy needs to be with the radiation, because the mastectomy is removing all the breast. So there's not a high likelihood of it coming back because there's no breast tissue there.
Right. And if you're genetically inclined to have breast cancer, then you would be more inclined to have a mastectomy, double mastectomy, so that it won't show up in the non-affected breast
Correct.
in the future.
In general.
Also, yeah, I would say yes, with caveats.
With caveats,
You could
yes.
get in trouble for that. Some people will
Yes.
say that's
You
not
don't have
true.
to.
So these are somewhat, I would say,
These are broad generalizations.
nuanced conversations about those things.
Oh, okay.
You might be more likely to, but people will argue about these things. So,
Okay. All right.
but it is something that could impact your decision making. But yeah, I mean, the basic things are lumpectomy plus radiation, and almost all patients who get lumpectomy will need radiation if they have an invasive cancer versus mastectomy. And this is obviously one of the biggest bifurcation points in terms of the choice that people make, and they have real implications on short and medium term sort of what happens to you. So I think it's really important for people to get an understanding of what's what. And I think some people think that I think people try and oversimplify it sometimes. They'll say like, well, this is just one's a smaller surgery and one's a bigger surgery. I think that's probably a vast simplification of it. I don't think that's how people should think about it. I think they are different choices that have some positives, some negatives, some upsides, some downsides. And I think it should be thought of in a much more sort of nuanced and thoughtful way, as opposed to just simpler or more complicated, which I think a lot of people sort of think, where they'll think less surgery or more surgery. And that's not completely untrue, but I think it is a little bit more of a nuanced conversation. So,
and it's personal. It's like very dependent on the actual human and their sort of tolerance for risk and further screening and the anxiety around it. I find that that's very personal, but not everyone. So it's important. So not everyone is a candidate for a lumpectomy. And I think that's sort of a hard thing for some patients to sort of get their head around. And I feel like saying that if a breast surgeon tells you that you are not a candidate for a lumpectomy and you have to have a mastectomy, they really mean it, because I would say in general, the advice, the guidelines overall are that we want to do more lumpectomies than mastectomies. And that's very much so. If they're telling you you need to do a mastectomy, it really is. It's really, you're not a candidate for it.
but I think we should back up a little bit. I mean, I think very importantly, right? So top line things, lumpectomy and radiation and mastectomy can show equal outcomes in long-term survival, right? If done in the correct, they will be different. So top line survival is not superior to the other. Top line, right? So lumpectomy and radiation is done probably 70 to 80% of the time. And that is because the data has shown it has equivalent survival rates. Some studies would show, right, equivalent or
Which is
even
overall disease-free survival.
it has equivalent to mastectomy, which is complete removal of the breast, right? So these choices in general are not, if you just take them at top line, they are not survival questions, right? You can equally
No, I mean, so you're right. Katie's point is correct. Not everyone is a candidate for a lumpectomy. So if you take those patients out, if you just took the patients and say, I have this X cancer, it is amenable to a lumpectomy. If I do a lumpectomy plus radiation versus mastectomy, is there a difference in disease-free survival? And the answer to that would be no, right? So that outcome is equal. So that's important for people to know. And so the decision for making that between these two things is not on that. That's not where the side is. Now, Katie's point is correct. Not everybody is a candidate for a lumpectomy. That can have to do with a number of things. People can have what's called multicentric disease, where they don't just have one tumor in the breast, they can have more. People can have large tumors in a small breast, and now the percentage of tissue that you have to take out becomes so large that you're almost taking out the majority of the breast. So those can be reasons why people might not be. There's a multitude of reasons. So, but Katie's point is, I think, totally correct that um, the general move in this country, the general progression is to do lumpectomies in most patients, right? And to only do mastectomies in patients who have a reason to not have lumpectomy. And that could be physical, like anatomic, that could be genetic, that could be patient choice. Those are probably the three biggest reasons why people will not get lumpectomy plus radiation. So I think that's just an important thing to set the sort of table so that everybody understands like how this process goes and just sort of the way that most people are going to, which buckets people are going to fall into. So let's just start there because I think it's important for just people to understand. Because I want everyone to, everyone should know here that the goal, of course, is to treat as many people as efficiently, as effectively as possible and maximize survival for as many patients as possible. And that's everyone's goal here. And their choices within that, but that is always going to be the goal. And that's what's going to be driving all of the choices, right? Where none of us are making, no breast surgeon is making a inferior choice in terms of this, right? They're going to be making some choices and talking to you about what they are, but they're only going to have these conversations for what they consider equivalent outcomes. They're not going to give you one option that has an inferior outcome to the other. So that's super important.
Right. That's the point.
That's
actually.
the point,
Yeah.
right? Like their job is to keep you alive, right? And save and maximize your length of life and disease-free survival.
And I've actually even heard breast surgeons say to patients, like, I'm in charge of you. Like, if something bad happens to you, like, it's on me. So I do think they really genuinely feel that way.
Can I ask you about your choice?
Sure. I guess I knew, I knew for the whole, I knew that I would choose mastectomy. Um, if I had to go through this, I just knew I would. I couldn't handle like
You
the
always knew.
screening. Yeah, like as soon as I, ever contemplated having breast cancer, which having worked with breast cancer patients my entire professional career, I've thought about it all the time. So, um, um, I knew that's what I would do, and I am fortunate in the fact that am a small-breasted woman that I was able to have nipple and skin sparing mastectomy, which, it provides benefits of being like sort of less, it's just cosmetically a little bit easier to tolerate. And I was lucky in that. So, I was lucky in that, but I knew I was going to have both. I just couldn't go back and couldn't go back for screening. It was a pretty difficult thing for me to like go through the process of having the biopsy, going through the uncertainty of it. It was pretty, I just couldn't imagine going back.
Yeah, I think we'll get into in the next episode when we talk about reconstruction. We'll talk about some of the implications of what those choices mean in terms of the physical side of it. But I think Katie's point is really important for people to understand here. So one of the most important things. So if you are going to proceed with lumpectomy and radiation, that means you are going to keep your breasts. You're going to keep both breasts, right? So
Which includes the sensation, which is
right. What that means is that you will continue to have surveillance of your breasts for the rest of your life. And so that you need to know yourself, and you need to know what that's going to be like for you. I have patients that have no qualms about going for surveillance. Their yearly or Q6 month mammogram is not a big deal for them, and they just go, and they're fine. And I have other patients who a month before, 2 months before, are starting to think about it, and they're kind of stressed about it. And the week before, they're just an absolute mess, and then they go, and then they're waiting, and that becomes this really large, like, just stress
Cycle.
point. It's a stress point for them, and it is really, really hard for them to go through it. And neither's right and neither's wrong. It's just who you are, and knowing and trying to understand where you think you're going to be in terms of that is important, because if this is going to be your life, and if you feel like it's going to be a huge emotional strain,
Sure.
that is something that you should think about. So it's important to sort of know where you're at with that, I think, to help you sort of make the decision, because some of these choices are going to be absolutely emotional, and sort of what you want to go through, your time of life, where you are in life, if you're younger, if you're older, if you have kids, if you don't, if your kids are small, if your kids are old. There's a number of things that are going to factor in. I think it's really important for people to feel empowered in the decisions that they make, because as we just said, like, we are giving people a palette of decisions that we think can give them the same outcome, right? And so then the question becomes, okay, so then what's best for you, right? And I think that's super important, and people should consider these things, because these are, you know, it's good in a way. We can take the top line survival thing off the table. That's like actually not something you have to worry about. We're not saying like, oh, this choice is like, that's off the table. So you can assume like, okay, I can pick any of these things, and I should be fine. I should be equally fine, is maybe not everyone's going to be fine, but you'll be equally fine, right? If you've been giving these choices. So then you can start to think about the other parts that may have an impact on what's a good choice for you. And I think that's something that we want people to think about and understand. It's really easy, I think, for people to feel like they don't have choice, or they just want to get through with it, and then people can have regret later. And we don't want people to do that. We want people to sort of think about things and take a little bit of time, try and understand themselves and make good decisions for themselves.
It takes time to understand yourself, though. And like in the moment of this, it can be
Yeah,
overwhelming
absolutely.
because like you're dealing with this scary news at whatever time in your life. And it's not, it's just hard. But give yourself a little bit of grace to sort of like just understand that it's a tough time, and lean on the people that you have around you.
That sounds like the best advice. I'd like to, if I can, carry on with some of the questions that we would be considering talking to the surgeon. You mentioned earlier a possible lymph node biopsy. Can we talk a little bit about how lymph nodes could be involved?
So cancer spreads from the breast to what's called the sentinel lymph nodes. That's the first one that it will spread to, and they're in the axilla, in your armpit, basically. So in the surgery, when you have either a lumpectomy or a mastectomy, they inject either a radioisotope in your arm, no, in your breast, sorry. In your breast, they inject the radioisotope or some dye that will drain the breast, and that will identify this sentinel lymph node, the first one. And they will check that to see if it has cancer, with the idea being if that one doesn't have cancer, that it has not spread out of the breast into the lymph nodes. So that's what they.
Yeah, I mean, do you have any sense of what lymphatic drainage is, a lymph
Well,
node,
I
as like a
do because
layperson?
I'm a colossal geek, but maybe we should
Okay.
talk to our friend.
Well, I think so lymphatic channels and lymph nodes are throughout the body, and they are one of the ways that our body clears infection, debris,
Waste.
And so I think the easiest way to think about it is like when you have a sore throat and you can feel like the lump in your neck and it's sore, right? That's because you have an infection in the back of your throat. The lymph nodes in your neck drain your throat. And so that inflammation or infection is traveling into those lymph nodes, and they're sort of a clearinghouse, and it goes through there. So that's how lymphatic channels work. A particular territory has an area that it drains to of particular lymph nodes. And so in certain places, it's really anatomically defined. Other places, it isn't. In the breast, it's really well anatomically defined. There's really only two places where the breast will drain to the armpit, where you do have some lymph nodes along your sternum, but those are minor. So the vast majority of the time, the lymph nodes of your breast are going to drain into your armpit, your axilla, and then from there they go beyond that. So the sentinel node, if you think of it as like I would say it's sort of like a root system. It's like you've got one and it branches to another and it branches to another and it branches to another, and there's lymphatics everywhere, right? So sentinel being coming from the word sentinel, the one who's keeping watch. It's the first one. It's the first lymph node that your breast drains to, and then it will subsequently drain to others. And so the idea is if the first lymph node is clean, there's no good reason why it should, if it was truly the sentinel lymph node, then the ones past it should also be clean. So that's sort of the idea. So that's why they test this one first. If that one is positive, then we don't know what is beyond that, right? So then we need to do additional testing. They would do additional testing of subsequent lymph nodes to get a sense of how far down the chain has this gone. And so you can have what's called a total lymph node dissection, which they remove 15, 20, 25 lymph nodes and test all of them and see how far. So sentinel lymph node is standard of care for basically anybody who has an invasive cancer. That is going to be done in almost all patients, pretty much all patients.
There are caveats.
There are caveats.
There's like things are changing to de-escalate
Correct.
that in sort of older people that are lower risk for.
Studies are ongoing to try and do less, but currently most patients are going to get that. So it's a very common conversation that you're going to have. And this is something, I mean, I assume they're going to say this more artfully than I did, but that's the basic idea of what that is. And so in most patients, a sentinel lymph node will be done at the time of the operation to remove the cancer. Sentinel lymph nodes in general are analyzed while you are asleep. In most centers, they are analyzing them either with frozen section, touch prep, something to get a sense of whether or not the lymph node is positive or not. If that lymph node is positive, then they will often take more lymph nodes at that same surgery in order to, as we talked about, try and figure out how many lymph nodes are involved. So that is the typical way. Again, as with all of these conversations, there are going to be some caveats, but that is often what will happen. So most patients, when this initial surgery, the first surgery is done, will know should know their lymph node status. Not you won't know when you wake up, but within a week, 10 days, whatever, you will know your lymph node status.
Would you ever know your lymph node status before?
Yes. If on the ultrasound or imaging there's suspicious lymph nodes, or they feel your armpit, they feel something that feels firm or hard, and then they would do a similar biopsy, a needle biopsy of it. And if that comes back to have cancer cells in it, then they will put a clip and tag that to let that be known that that's where cancer cells were. And then in those people, they most likely will have chemotherapy before surgery.
That puts you in the group of potentially needing neoadjuvant. Neoadjuvant meaning before treatment of the primary.
Okay, and there would never be a circumstance where your lymph nodes would be cleared before surgery. Surgery is the ultimate
Correct.
arbiter of being okay.
Yep,
Okay.
that's
All right, good to know. That's good to know. So
and that's a big predictor of further treatment that you will need. So it's like I mean, there's lots of points along this where there's more information but the lymph node status is one of the
it's huge.
most important
When
things.
I call patients' families, if the lymph node came back negative, I will always say, well, the biggest news of today was the sentinel lymph node was negative, because that is just like a huge bifurcation point, right? So and people should know that. Like, if your lymph node came back negative, like, congratulations, that's phenomenal news. I'm thrilled. Like, you should be thrilled. Your whole family should be thrilled. It's amazing news. That's great if that's true. And so, yeah, I think that's like, it's one of the most important things. Should not be understated.
When I woke up for surgery, the first thing I asked was about my lymph node like 47 times, which was not the best news, but it was still I was like barely awake. Do you remember?
Yeah.
And I was like, what was my lymph node? And then they were like, we'll talk to you about it later. I was like,
Oh man.
I know.
Yeah. So important
It's
stuff.
like a
Yeah.
very important thing.
All right. Wait, so we were getting into the surgery. I don't know if we spoke a little bit about different approaches to mastectomy. Did we get into that?
You're likely to hear that there are two choices in general to treat breast cancer. So, the first choice is a lumpectomy, which is removing the cancer as well as a area of normal tissue around it, and this would be done in conjunction with radiation therapy after surgery. And then the second choice is doing a mastectomy, which is removing the entirety of the breast. So not just the cancer, but the cancer and then all of the additional breast that's around it. If you have cancer that is multicentric, meaning in multiple quadrants of the breast, how big the cancer is, and then also sort of reasons personal to yourself that you don't want to go for radiation. You don't want to have further mammogram screenings in the future, to have to go through that process in the future. So those are some of the main reasons that someone would pick to have a mastectomy over a lumpectomy.
But I think it's important to know. I mean, so it's about 70-80% of people are getting lumpectomy and radiation versus mastectomy. I think it's important for everyone to know that is by far the most common way of treating these cancers, and there are real benefits to that. As you alluded to, it's breast conservation for most patients. There's not, in general, huge cosmetic implications to that. It is certainly less surgery, and there's less need for subsequent surgeries in terms of for cosmesis and other things like that. So there are things about it that are really helpful, and the survival outcomes are really good. And I do think many patients are fine with the surveillance. They handle it just fine, and it's not something that is particularly worrisome to them, and they go through it without too much worry, and people do fine, and that is clearly the majority of people. But it is a something that you have to know yourself. I think some people really do have a really hard time with it, and trying to figure out how you're going to be with that, I think, really makes a difference. Because I think Katie and I have seen patients who, they may be getting Q6 month mammograms for a while, and every 2 months before, a month before, they start to think about it. They start to stress about it. A week before, they're absolutely kind of like can't handle it, and they're just like really, really bothered, distracted, and then they're sweating it out while they wait for the results every time. So it is really important to understand yourself and what you think is going to be right for you, and how you're going to emotionally handle it, because it has implications over your life. So it is something to try and think about. It can be a little hard to know where you're going to be. Maybe you'll have some sense, but it is something to think about and be thoughtful about, because it is going to become a big part of your life.
I do think it's notable saying that if they offer you both choices, you're a candidate for both choices. If the breast surgeon says to you, you need to have a mastectomy, meaning you're not a candidate for a lumpectomy, that is something generally you should listen to, because they, as Vish pointed out, 70% to 80% of patients are getting lumpectomy and radiation. So it is it's de-escalation of surgery, it's less surgery, it's breast conservation. I think it's the preferred treatment. So if they're saying mastectomy, then it's something that you definitely need.
Yeah. In 2026, I don't think there's many surgeons that are rushing people for mastectomies. That the paradigm has really shifted on that. So Katie's point is right. And why does she say that? It's because we sometimes see people who really, really don't want to have a mastectomy and sort of try and force the issue of having a lumpectomy for cancers that are either too big or too aggressive or too, there's a lot of twos. There's a lot of things that can be, and those patients have problems over time. So I think Katie's putting kind of like a PSA out there. Like if they're telling you you need it, you probably need it. And I think we'll get into the implications of having a mastectomy in terms of the aesthetic outcomes in like future episodes. But if you need it, it's because they think that the outcomes are no longer equivalent, right? So it's really important for everyone to understand that these two interventions yield equivalent outcomes in the in correctly chosen patients. So that's important. If they're suggesting you need mastectomy, it's because they don't think that they are equivalent at this point. That there is a benefit to having a mastectomy, and so occasionally that is cosmetic and really because they think it'll be too much of the breast removed or too deforming or distorting of the breast. But a lot of the times it's for oncologic reasons, and I would say that's the majority of the time is for oncologic reasons. So it is important to understand why it's being advocated for and to try and listen to them in that scenario.
After the surgical consultation, you're going to have the plan of the surgery, hopefully. But as it's kind of a difficult decision for some people, they may want to have additional information. So like if you're deciding between mastectomy and lumpectomy and you're not quite sure, the breast surgeon is also going to talk to you sort of broadly about the plastic surgery options for if you have a mastectomy to have breast reconstruction. They're going to talk to you broadly about it, that you can either use implants or you can use your own tissue, and they're going to talk to you about that just broadly. But they're also going to send you to see a plastic surgeon that's going to go more in depth with that to help you make the decision. So while you think you may be like, I'm going to do a lumpectomy, but then they have you meet with the plastic surgeon anyways, and then we talk to you about it more, and then you're like, change your mind. So you're going to get further information, and then genetic testing as well.
And that brings us to seeing a plastic surgeon, which we will talk to in our next episode next week. All right. Thanks.
Thanks.
Thank you.
This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not disregard or delay in obtaining medical advice for any medical condition and should seek the assistance of their healthcare professionals.